My name's Paxton Bach. I am the program director for the Addiction Medicine Fellowship, and it brings me great pleasure today to introduce Dr. Jean Wang, who's going to speak to us about a topic that is near and dear to my heart. Dr. Wang is currently a GIM fellow here, a general internal medicine fellow at the University of British Columbia, as well as one of our clinical addiction medicine fellows. She previously completed her core med school and core medicine training at the University of Ottawa before relocating out here to pursue further specific training in addiction medicine. And to speaking to today's topic, her research interests are really around optimizing the treatment of opioid use disorder in the context of the fentanyl era. She's going to be speaking to us today about a medication we all know well, and we've been using clinically for more than 60 years, but surprisingly still have not talked about in great detail around how to optimize its use in the context of the fentanyl era. So I'll let Jean introduce the rest of the subject, but she's going to speak to us today about using methadone in the fentanyl era. I'll ask everyone to hold their questions till the end, and we should have about 10 minutes at the end for Q&A.
So, thank you for that very kind introduction, Paxton. It's a pleasure to be here today to be talking about a topic that I think is really important. You know, we prescribe methadone all the time, but what does the data tell us about how do we optimize it amidst the toxic drug crisis? Before we dig deeper into this topic, I would first like to acknowledge that we're humble guests on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And much of this work really disproportionately affects our Indigenous populations. And so, you know, we're grateful to be able to be on the land today, to be able to talk about this topic. And I hope that we can reflect throughout the presentations regarding our privilege and this data and how we can apply it to our Indigenous populations. I am a fellow with no conflicts of interest to declare. So in terms of background of this presentation, so we'll first talk about kind of the background of fentanyl, what is the fentanyl era. We'll talk about the efficacy of methadone in the fentanyl era. We'll talk about current prescribing patterns as well as challenges, and then how do we optimize methadone prescribing in this fentanyl era. Now, you may be asking yourself, why are we talking about methadone in a What's New presentation? Methadone's been around since the 1930s. It's been an effective treatment for opioid use disorder since the 1960s. And there's really strong RCT level data as well as systematic review, meta-analysis data to support that it improves mortality, morbidity, as well as retention and treatment in patients with opioid use disorder. But I think it's so important for us to take a step back amidst the toxic drug crisis that we're living in and reflect on how do we optimize the evidence-based treatments that we know work with the evolving data. So during this presentation, I want you to reflect on, first off, these questions. Does methadone work in the fentanyl era? What does the data tell us about that? What are the current challenges in prescribing and the patterns of methadone use in the fentanyl era? And how do we optimize methadone prescribing? Just some background. So heroin is an opioid that is derived from the dried latex of the opium poppy. Whereas fentanyl is a synthetic opioid. It's completely man-made and synthesized in a laboratory. And it's estimated to be around 30 to 50 times more potent than heroin. I also want to remind us that as we talk about the fentanyl era, we're actually talking about the era of fentanyl analogs. So there's all kinds of fentanyl analogs with different potencies from carfentanil, sufentanil, remifentanil. Across BC, the most commonly detected is still fentanyl itself, but in a 2024 study, they found that methylfentanyl and fluorofentanyl were the kind of second most common. When is the fentanyl era? To go over a bit of a timeline, so the US timeline is a little bit different than our Canadian context. So in the US, they talk about this three-wave opioid epidemic, where in the 1990s, this wave of prescription-type opioids, followed by, in 2010, a rise in heroin-associated deaths in the US. And then 2013 is when the US saw a rise in fentanyl related deaths in the US. In BC, we saw this rise slightly later. So around 2012 was our first documented death with fentanyl detection. Certainly fentanyl could have infiltrated the market slightly earlier, but that was our first documented death. And then around 2016 is when we saw a sharp rise in deaths associated with fentanyl, and a public health emergency was called in Canada. This is data from the BC Coroner Service looking at causes of an unnatural death in BC. So you can see here back in 2014, unregulated drug deaths were pretty comparable to homicide, prescription drug use, suicide. And then around 2015 is when we started to see a rise. In 2016, a sharp rise in unregulated drug deaths, which are continuing to rise even in recent years. This sharp rise in unregulated drug deaths corresponds with the percentage of fentanyl detected in these patients. So you can see here in 2014, 2015, around 25% had fentanyl detected in unregulated drug deaths, versus that sharp rise again in 2016 to around 70%, and more recently around 80% of these deaths had fentanyl detection. This is to give you a sense of the proportion of opioid containing samples across Canada with fentanyl or fentanyl analogs. So you can see here an east versus west gradient, where BC is the most disproportionately affected, but kind of Alberta and then Ontario are also highly affected, with our Atlantic provinces seeing the least burden of fentanyl or fentanyl analogs in their supply. So now we'll talk a little bit about the effectiveness of methadone in the fentanyl era. And first off, we'll establish the overall impact of methadone, even in data before the fentanyl era. So we know that methadone reduces all-cause mortality, overdoses, and improves retention and treatment. And this is best illustrated in one of the major systematic reviews and meta-analyses published in 2021, where they looked at 15 RCTs and 36 primary cohort studies. And what they found was that all-cause mortality was reduced by half on methadone, with a relative risk of 0.47. This is a forest plot to illustrate from the same systematic review. And you can see here a clear trend towards favoring being on methadone in terms of mortality. Other impacts of methadone: it was associated with a lower risk of suicide, cancer, drug-related mortality, alcohol-related mortality, as well as cardiovascular mortality. And of note, aside from the mortality and morbidity improvements associated with OAT, there's also other impacts. So starting patients on opioid agonist therapy has been shown to be associated with lower rates of leaving hospital against medical advice, as well as lower 90-day readmission rates for patients who are discharged on OAT. In comparing methadone versus buprenorphine, fairly comparable in terms of efficacy outcomes. The main difference we're seeing here is in retention, slightly favoring methadone. So this effect is seen in a systematic review of about 80 studies published in 2022, where they show that methadone was marginally superior to buprenorphine in terms of treatment retention. And then in terms of real-world data, based in BC, there was a retrospective study where they looked at about 40,000 patients, and they found that there were lower monthly discontinuation rates amongst people receiving methadone versus buprenorphine. So about 10% versus 21%. Looking at data specifically in the pre and post fentanyl era. So this study looks at the impact of OAT on mortality. So it was a retrospective population-based study in BC of about 50,000 patients. And they looked at the standardized mortality ratio of being on OAT versus off of OAT. And similar to what we just highlighted, being on OAT was associated with a significantly reduced risk of mortality. But what's interesting here is they also demonstrate the risk of mortality over time. So before the introduction of fentanyl, that relative risk was about 2.1. After the introduction of fentanyl, that relative risk actually increased to 3.4, suggesting that OAT is possibly more protective in the fentanyl era. You can see the curves here, that there was actually an increase in the separation after 2016, after the public health emergency was announced. This study was looking at overdose deaths, as well as patients that were on OAT and their characteristics. So it was a linked admin database study where they looked at about 3,000 deaths, and they looked at BC Coroner's assessment of which substances were relevant at the time of death, and then their linked prescriptions on PharmaNet. And essentially, this population had high rates of fentanyl use. So 80% had fentanyl or fentanyl analogs detected at the time of death. Prescription opioids, very small proportion. 2% of patients had only prescription opioids felt to be relevant at the time of death. And then 7.8% had both prescription opioids and illicit opioids relevant at the time of death. And only 7.4% were on OAT or had OAT relevant at the time of death deemed by the coroner. So this really illustrates that the majority of overdose deaths that are happening in BC are in patients that are not on OAT. And then when we looked at the patients that were had OAT relevant at the time of death, these are patients, they looked at, actually many of them did not have an active script, or in the patients that were on methadone, the majority of those patients were on doses less than 60 milligrams, suggesting that OAT is protective in a patient with patients with high rates of fentanyl use, and yet most overdose deaths are happening in patients that are not on OAT. This study is a naturalistic follow-up study retrospective review conducted at Rhode Island, where they specifically looked at retention rates and remission rates in patients who used fentanyl and who didn't use fentanyl. So about 150 patients, 121 of them were fentanyl exposed at baseline based on their urines. And in looking at the retention rates at 12 months, pretty comparable on methadone, 50% in those fentanyl exposed patients versus not fentanyl exposed. And then prolonged remission rates were also comparable in 40% across both groups. 99% of patients who remained on treatment at 12 months achieved remission, and there were no deaths in this population, suggesting that methadone is still protective in patients who use fentanyl. And what are the mechanisms of overdose production of methadone? Well, it really acts to reduce cravings, withdrawals, thereby reducing the amount of fentanyl use and reducing exposure to fatal overdoses. Furthermore, it maintains your opioid tolerance. So if there's a period of time where patients don't have access to fentanyl, or they pause in terms of their use, and then they use again that same amount, that increases their risk of fatal overdose. And so being on methadone can maintain their tolerance during that time. So now we'll talk a little bit about the methadone prescribing patterns and challenges in the fentanyl era. So this is data even pre-fentanyl era, but just illustrates the challenges with induction or starting people on methadone. So this is a BC population-based study where they basically looked at what percentage of inductions are completed when we try to start patients on methadone. So over about 200,000 episodes, they found that less than 60% of methadone inductions actually completed induction. And then of the 60%, less than 50% of them actually achieved minimal effective dosage, so 60 milligrams daily. So while we have a highly effective treatment that reduces morbidity, mortality, we're still having a really tough time completing inductions and retaining people on treatment. Treatment retention in patients who use fentanyl. There are some higher rates in qualitative studies reporting treatment dissatisfaction in patients who use fentanyl, which is associated with increased treatment dropout. And there's also higher rates of cycling in and out of treatment in people who use fentanyl compared to prescription opioid use. Now, this is some interesting data based in ISIS in Ontario, where they looked at about 70,000 participants, and they looked at retention rates over time over a course of 2014 to 2022 and trends. And what they found was that the mean treatment duration on OAT or methadone was 193 days between 2014 and 2016. Compared to more recently, 2022 to 2020 to 2022, the mean treatment duration was 86 days. And you can see this effect illustrated on the blue curve, 2014 to 2016, versus the green curve more recently, that there's higher rates of or faster time to discontinuation of methadone. This suggests that maybe patients who use fentanyl may be harder to retain in care, although the alternative hypothesis may be here that we might be accessing patients or reaching populations that are just harder to retain in care. What are the prescribing practices in the fentanyl era? So most of this is based on qualitative research. So some qualitative research based in the US have shown that 90% of OAT prescribers have already shifted their OAT prescribing in the fentanyl era, despite many of the guidelines still being based on data from the heroin population. And 60%, specifically in a US context, felt very limited by the regulatory guidelines in terms of their prescribing. Many experts, like the Medify guidelines and commentaries, are calling for increased doses needed to retain patients in the fentanyl era. But despite this widespread clinical experience that patients who use fentanyl need higher doses of methadone, the data is actually pretty limited on what doses are effective for patients who use fentanyl. So now we'll shift gears a little bit and talk about how do we optimize methadone prescribing in the fentanyl era? What does the data tell us? And first we'll talk about induction and rapid methadone titration. So in order to understand methadone titration, we first have to understand the pharmacokinetic. An average half-life around 24 hours, but it's really variable. So it can range anywhere from 9 to 59 hours. And so steady state is typically achieved in 5 half-lives. So that would be typically 5 to 7 days being on that same dose to achieve steady state. So you can see here in this curve, even though patients are receiving the same dose of methadone 40, the dose that they're actually seeing in their bloodstream accumulates every day. And because of that slow accumulation or that risk of accumulation, current protocols or guidelines recommend slow titration of methadone at the start. There's also an increased risk around the time of induction with methadone. So we see here that mortality in the first 4 weeks after initiation of treatment is 4 times higher than the rest of their time of being on methadone. And it's interesting because this effect is not seen necessarily with buprenorphine. So in this systematic review, the chart here on the top right, you see here the risk of mortality with time since treatment initiation. And you can see here, while the risk of mortality drops off quickly, those first 4 weeks are a high risk period. The curve at the bottom here illustrates when patients fall out of methadone treatment, their risk of mortality. And you can see here a sharp rise out of methadone treatment. So what accounts for this increased risk of mortality around the time of induction with methadone? The causes of this are not entirely clear. Some say may be related to methadone toxicity with the slow accumulation, as well as concurrent sedating medications at the same time. But what's more likely is that patients, because it takes so long to get to a therapeutic dose, they might have ongoing cravings and use during treatment and use on top of their methadone as well. Or there might be a period of time of abstinence where they lose tolerance and then they resume use because of these cravings and are at risk of fatal overdose. So the current guideline titrations that recommended, so the BCCSU recommends a maximum on day one, a starting dose of 40 milligrams in patients with known very high tolerance. So current fentanyl use, as well as prior experience with methadone. If they have lower tolerance, then depending on their tolerance levels, the starting doses vary. Titration after the first day is also guided by how their tolerance as well. So 15 milligrams every 3 days for those with the highest tolerance, and this is as an outpatient up until 85 milligrams, and then start to slow down the titration after that, or slower if patients have lower unknown tolerance. Just to give you a sense of how this compares to protocols across North America. So the American Society of Addiction Medicine guidelines in 2020, they recommend a similar initial dose to the BCCSU, a max of 40 milligrams, but typically 10 to 30 milligrams. And then their titration is a bit slower than ours, so a maximum of 10 every 5 days. In Ontario, they have the Medify guidelines, and their initial dose is a bit lower than our BCCSU guidelines, so 30 milligrams in 2021, with a similar titration schedule of 10 to 15 every 3 to 5 days. Earlier this year, actually, they released an update, and they've now changed the initial first day dose to 50 milligrams for patients with really high tolerance, no risk factors for toxicity, such as elderly, concurrent sedating medications, and who've tolerated methadone in the past. So this is where rapid methadone induction comes in. So current guidelines, as you can see, could take weeks or months to reach a therapeutic dose for patients. And really, we have to balance the risks of methadone toxicity with the increased mortality from overdose from ongoing fentanyl use, as well as we know that patients who fall out of methadone treatment have an increased, tenfold increased risk of mortality in the first 4 weeks. So we really need strategies to help achieve therapeutic dose more quickly for patients. And so rapid methadone titration has been described in the literature. So the titration schedule you might be familiar with at St. Paul's is about 40 milligrams on the initial dose, and then 10 milligram doses every 3 hours as needed for a maximum of an extra 30 milligrams or 70 milligrams on day one. And this is typically done on an inpatient setting with monitoring. And while we're all very familiar with this protocol here, it's actually not super widely adopted across North America or other settings. And so what does the literature tell us about the safety of rapid methadone titration? So we recently did a systematic review looking at rapid methadone titration protocols in the literature. And what we found was that there was a wide variety of rapid methadone titration, both in heroin as well as fentanyl use populations, as well as inpatient as well as outpatient settings. There's a wide range, but this is just to give you a sense of the most common protocols in the literature. So 6 studies looked at a similar protocol to our St. Paul's. So they'd start at 30 to 40 milligrams plus 10 milligram as needed doses every 3 to 6 hours, with max doses on first day ranging from 50 to 80 milligrams. And then 7 studies looked at starting at 20 to 40 milligrams and increasing by 10 to 20 milligrams every day. This graph gives you a sense of what were the max doses on day 1 and what were the doses, average doses that were achieved on day 7. So in green here, you can see the max initial dose on day 1, the dark green, and then the light green is with top-up as needed doses, what was the maximum dose that was allowed on day 1. So you can see here quite a range from 20 milligrams all the way up to 150 milligrams in one study on day 1. And then in terms of the average doses that they were able to achieve on day 7 of induction, range from 50 to 100 milligrams. This graph gives you a sense of the average doses achieved on day 1, 3, and 7. So on day 1, you can see here that the average dose is generally between 30 to 50 milligrams, whereas with the BCCSU guidelines as an outpatient, it would be a max of 40 milligrams. On day 3, in the medium colored blue would be kind of between 50 to 80 milligrams average doses achieved, whereas with the traditional outpatient guidelines, you would still be on 40 milligrams on day 3. And then average doses on day 7 ranging between 50 to 100 milligrams. And then traditional outpatient guidelines, the max that you would achieve on day 7 would be 70 milligrams. What are the safety outcomes associated with this? So across 1,400 patients, there were 63 deaths that were reported. But of note, 61 of these deaths pre-selected for the outcome. So they were autopsy studies on coroner's cases conducted in patients that were part of a methadone program. And they were 2 Australian studies conducted in the 1990s on a patient population with unclear tolerance in an outpatient setting. So not everyone was using opioids every single day, or they were on prescription type or heroin. And then 2 deaths were reported in a prospective cohort study, but occurred in the context of superimposed heroin or other sedating medications. Of note, there were no deaths in studies in the fentanyl era and no deaths in inpatient studies. Looking at other safety outcomes, so overdose rates across 800 patients and 21 studies, there was less than 1% rate of overdoses. And then oversedation was a little bit more common, about 4% or 45 patients across 1,000 patients. But of note, with the oversedation, most events were mild. Most patients were able to continue on methadone afterwards with or without dose reductions. In terms of retention on treatment, there was one study that looked at retention across the US in about 14,000 patients. And what we see here is that higher doses, 70 milligrams or more, achieved on day 7 of induction of methadone was associated with increased treatment retention. So getting people on higher therapeutic dose faster was able to increase 30-day retention on methadone. In terms of patient-directed discharges, there was one study that looked at this and they compared a standard versus rapid titration in a pregnant population. They had about 170 patients. And interestingly, their standard titration was also pretty rapid. So this was done in an inpatient setting. So their standard was 30 milligrams plus 10 milligrams as needed every 6 hours, versus their rapid induction was up to 40 milligrams on the initial dose. And then they could get 20 milligrams 4 hours later, plus 10 milligrams every 4 hours. And what they found here was that in the rapid titration group, that there was lower rates of elopement from hospital, as well as lower rates of methadone-related readmissions. And this did not compromise safety. So overdose rates, pregnancy outcomes were comparable across groups. So we know that with methadone titration, the initial period is a high-risk period. But what the literature suggests so far is that overall event rates, adverse event rates with this are fairly low. So no deaths in inpatient settings or the fentanyl era. Overdose rates are less than 1%, and oversedation rates are their events are generally mild, and most patients can continue on methadone afterwards. It is important to note that adverse events were noted, and so applying rapid methadone titration in the right populations is super important in patients with known high tolerance or having the infrastructure like inpatient settings, monitoring to be able to implement this. And also note kind of caution in patients with concurrent sedating medications, alcohol, or elderly. Next, we'll talk a little bit about maintenance doses. So prior to the fentanyl era, an effective dosage based on heroin data was around 60 to 100 milligrams. We know that experts are calling for increased doses of methadone in patients who use fentanyl, and that the majority of prescribers are already shifting their prescribing patterns in the fentanyl era. There's some qualitative research on this. So one study looked at patient perspectives on their doses of methadone and felt that they needed higher doses of methadone after using fentanyl. But some conflicting data study done by our very that looked at perceiving their methadone dose to be too low, and it wasn't significantly associated with fentanyl. So we really need more data in this area. And it's surprising that we're 8 years into this toxic opioid crisis, and we still don't have great data as to what maintenance doses are optimal in patients who use fentanyl. What we do know is that higher doses of methadone are associated with increased retention. And this is illustrated in a Cochrane systematic review, as well as a BC population-based study where they found that higher doses, higher than 60 to 100 milligrams or 120 milligrams, was more effective at retaining individuals, more effective at reducing heroin use. And so we really need more data in a fentanyl population to know what doses are optimal. Lastly, we'll talk briefly about missed dose protocols. So the missed dose protocols are implemented because loss of tolerance could occur within 3 to 4 days of patients not taking opioids. With the longer half-life of methadone, though, loss of tolerance may take longer. And also, one thing to consider is that many patients, when they fall off their methadone treatment, they're resuming use and actually maintaining their tolerance during this time. So some of the challenges with missed dose protocols is that over-reduction in doses could contribute to ongoing cravings, opioid withdrawal, and treatment disengagement or return to illicit use. Currently, peer-reviewed studies on evaluating methadone restarts are pretty limited, and so most of the guidance is through clinical guidelines and public health guidelines. To give you a sense, the BCCSU missed dose protocols, so generally 1 to 3 days, you can continue the same dose. At around 4 days, reducing the dose by about 50%. And then at 5 days is when you would essentially generally cancel the prescription, restart at 30 to 40 milligrams, depending on their tolerance. This is just to illustrate that across other guidelines, the WHO, the American SAMHSA, and the Ontario Medify guidelines, pretty similar to the BCCSU with some slight differences. These are some modified missed dose protocols that have been implemented in the US in outpatient treatment programs in the US. So the San Francisco Health Network in 2024 just released this guideline where they tend to, between 4 to 6 days, reduce the dose between kind of 60 to 80%. And then at about a week after a missed dose, that's when they kind of individualize or re-induce patients. Denver Health Protocol, also similar. So around 4 to 7 doses missed, they would actually continue if they had ongoing fentanyl use during this period of time. They would continue the same dose that they were on before. And then after 7 days, further provider evaluation is needed. There's a study in JAMA published earlier this year looking at missed dose protocols and evaluating a pilot study. So they looked at pre-implementation and post-implementation cohorts of this methadone restart protocol. And the outcomes that they looked at were safety outcomes, so ED visits, mortality, and then secondary outcomes were retention. And what's interesting about this protocol is that it was clinician discretion guided rather than necessarily a strict protocol. So pre-implementation period, if they missed 4 to 6 doses, they would reduce the dose by about 50%. And then 7 days, they would start over. Post-implementation period, if they missed greater than 4 doses, then they would allow the clinician to determine if they met the following criteria. So low risk features, not elderly, no concurrent benzodiazepine or alcohol use, or reliable history of ongoing use during that time period, and deciding between a dose reduction of between 0 to 30%. Versus if they didn't meet that criteria, reducing by about 50% as per the previous protocol. And what they found was that in the pre-implementation period of this protocol, patients were started on methadone doses that were about 30% lower than their previous. And then after implementation of the protocol, they were started on doses that were about 3% lower, so nearly their previous dose. And what you can see here is that this did not compromise safety outcomes, that all-cause mortality, ED visits were pretty comparable across groups, and treatment retention as well. So in conclusion, we know that methadone is an effective treatment for opioid use disorder. There's also good evidence supporting its efficacy in the fentanyl era. Some of the challenges are that treatment retention remains low, as well as our rates of achieving a therapeutic dose. And so novel strategies are needed, such as rapid methadone titration, in order to help achieve therapeutic dose sooner. And we need further research in this area to know what are the optimal maintenance doses in patients who use fentanyl, and missed dose protocols as well in patients who use fentanyl. Thank you for listening to this presentation. There is a survey I'm told to tell you guys to complete as well for feedback.
Sure. Yes, please complete the voluntary mandatory survey. Thanks, Jim. That was excellent. A really thorough overview and such an important topic. I'm happy to open it up for questions to the audience here or online. Yes, at the top. You have your questions for Scott.
Quite surprising how methadone had superior retention compared to Suboxone, and then you think is that most likely that epidemiology situation with the patient, the pharmacist there, or with your exploration of the literature, how do you come across any novel ways to administer methadone in the community? Because a lot of times patients they complain of like the same amount of challenges that the pharmacist or wait to get. My question is, any innovations in community dispensing methadone at Colorado?
Yeah, for sure. So just repeating the question for folks on Zoom. that surprising the data around methadone versus buprenorphine and the improved retention on methadone. And in this context, whether there's any innovations in terms of daily witness dispensing or easier ways that patients can access methadone in the community. So great question. This is certainly a challenge. And first speaking into the first part of the methadone versus buprenorphine, I think there's a lot of complex reasons as to why methadone might have better retention than buprenorphine. With the traditional buprenorphine inductions, they could be quite challenging with patients needing to be in withdrawal prior to starting buprenorphine. So a lot of treatment dropout was very early in that course. And then also buprenorphine being a partial agonist versus methadone being a full agonist. Some patients may just feel differently while they're on methadone. In terms of innovations, in terms of providing methadone in the community, I think methadone's been around for a century and we still haven't worked out like the best way to do this. Certainly with that high risk period, it is difficult to remove daily witness dispensing altogether. But in the fentanyl era, we do need to think about different innovations. So things like delivered doses to patients' homes, to their SROs are currently being implemented. So they're being witnessed, but coming into the homes. Of course, patients who are stable on methadone for quite some time, have some provider relationships, can have take-home doses of methadone as well. So there are really safety mechanisms that are being implemented in place. But you're right that methadone's been around for a century, and I think that there are ways that we can do this better. We just haven't figured it out yet.
Yeah, if I can just add, thank you for that answer, but I'll add to that question because it's a really important one. This is an observation that's pretty consistent globally that methadone's got better retention than buprenorphine, and the way that they're prescribed and administered is not consistent necessarily around the world. So there's probably some of it has to do with fundamental pharmacologic differences between the two, but it's really hard to separate them from the structural ways in which we administer and the differences there. But you've hit on a question that was sort of the guiding question behind our 2023 opioid use disorder guideline updates, was how do we address reasons for dropout with our various medications? And there has been a lot of changes in the last 2 years in Canada around take-home doses for methadone to address your exact question, because daily witnessing is clearly being articulated as a barrier for retention by people who are on methadone. And so access to take-home doses now is much more accessible than they were 2 years ago, at least on paper. Whether that's actually translating into practice yet is a different question. Any other questions here? I'm looking online. So if you have any questions online, please type them into the chat box. Yes, Ainsley.
Thanks for a great presentation. Do you foresee the guidelines changing, and is this being disseminated for community practice, for community primary care? And just wondering, this is kind of being shared, is this being known better from others out in the community?
Yeah, that's a great question. So the question was around participant who is based in the community and whether this information is being disseminated or shared and being implemented in upcoming guidelines. So the discussion around rapid methadone titration and all of these innovations are really increasing in conference meetings as well as amongst the population. And so we recently just performed the systematic review and are publishing the results. And we hope that with this increasing data in this area, that it will inform the upcoming guidelines. Of course, there is always a bit of a data to implementation delay, but that's in part the reason why we've kind of gathered this data in the first place. Is even before that, the data is quite limited. And when we look at the studies on rapid methadone titration, most of them have been published in the last 2 years. So prior to that, there was quite limited data. So now that we're getting this emerging research, hopefully it will inform future guidelines. And Paxton probably can comment a little bit more on the guideline development committees.
no, it's a process, but I think Jean's highlighted how promising this is, but also that there are harms, and so we need to know more about how to do this safely in who and where and when.
I do know when I worked in community that we had training for Med 101, Med 201, and for the methadone at that time. It was in-house, they lived there, and we had the extensive med program there and at each site. So it was readily accessible and seamlessly accessible. But if they went off, like the study said, for 3 days, they'd have to go and make an appointment to see the doctor again. But we had worked with like downtown East Side Clinic and Strathcona, and we all were on the same page when it came to the methadone administration. So yeah, that was a very good, I think they still have it in use.
Yeah, that's awesome. I mean, certainly there's all kinds of like community projects. I heard of, I think Columbia Street was starting people as an outpatient on 80 milligrams of methadone. So I'm curious, like how can we better put our data together and kind of come together to share these ideas and understand better what are the impacts, the safety, the efficacy of these protocols. Yeah.
Hi, Jean. Thanks for a really interesting talk. I'm curious on the flip side. Just anecdotally, when we're trying to get people on methadone, have like a maybe theoretical ceiling of 200, no more than 300, let's say. But did you come across any data looking at what guides that thought, or any efficacy maybe beyond a certain dose for treatment retention or other benefits?
Yeah, so the question from Felicia, for those online, was asking about whether in very high doses, methadone, like 200, 300 milligrams, if there was data looking at whether there's a ceiling effect and what we know about kind of higher doses of methadone. Yeah, so this is a great question, and I thought deeply about this because I thought it would come up in our conversation. So what we know, looking at the retention data of methadone, we know that 60 doses greater than 60, doses greater than 120 milligrams are more effective at retaining patients. There was not a lot of literature. I specifically looked for this to see what are the kind of ceiling doses or the highest doses of methadone that might be effective. And I think part of this is you know, at some point, even though methadone is a full agonist, at some point, the agonism effects would taper off. And so with higher escalating doses of methadone, we're not necessarily seeing improvements in cravings and withdrawal symptoms. And so patients, as we get to those higher doses, like 200 or 150, even higher, we really have to ask ourselves as prescribers, was there an improvement with the previous dose increase? Did they notice a difference? And if they're having ongoing cravings as well, is there kind of, what are their cravings driven by? Because we know that opioid use disorder is not just a deficit of opioid agonism. It's very multifactorial, and cravings can be driven by triggers, social, psychological. So long-winded answer to your question is that I, in the literature, have not seen a specific ceiling dose of methadone. Does it exist? I do think at some point when we titrate patients that higher doses are not the answer. But that being said, we need a bit more literature in this area.
Any other questions? If not, stay tuned for more work from Dr. Wang on this subject. And thank you all for attending today. Thank you for a wonderful presentation.